Assalamu alaikum. Surgery plays a major part in the management of nasal polypi, but recurrences of the nasal polypi after surgery are common and in some patients groups very common. That's why in almost all patients of nasal polypi, non-surgical options of management should be considered. Recurrent nasal polyps are common. If you look carefully for evidence of a recurrence by nasal endoscopy, a large cohort study had found that 40% of the patient had nasal polyps recurrence within 18 months of the original operation. Half of this number, like 20% of the original cohort, had revision surgery within 5 years of the original operation. Nasal polypi are not all the same. They differ. They differ according to the pathological inflammatory response that is responsible for their production. In the Caucasians, for example, it's usually the inflammatory subtype dependent on T cells helper 2 that recruits eosinophils and this releases IgE. In Asians, like from reports of Japan, China, and South Korea, it's more of the Th1 type of inflammatory response with neutrophils recruitment. It's becoming increasingly important to differentiate between the subtypes, the phenotypes, and the endotypes of the nasal polypi, particularly with the introduction of monoclonal antibodies in the management of nasal polypi. It's important to differentiate between different subtypes. Different mediators like IgE, interleukin 5 or interleukin 4 or interleukin 13 are all employed in the inflammatory pathway, and if you want to block this pathway by specific antibodies, it's important to be able to differentiate between the pathological subtypes of the polypi. Microscopic examination of the nasal polypi would reveal excessive amount of extracellular fluid in the stroma. The covering epithelium, which is usually respiratory in type, would have some metaplastic areas, and the basement membrane, the reddish part, is thickened. But it is the type of the infiltrating inflammatory cells that would help in differentiating between the different subtypes of the polyps. In the type 2 T helper cell pathway, it's usually eosinophils in the stroma and in the basement membrane, while in type 1 T helper cell pathway, it's usually neutrophils. In addition, there would be also mast cells, lymphocytes, and plasma cells, and various inflammatory mediators, including interleukins, particularly type 5. There will also be interferons, macrophage colony stimulating factor, eosinophilic cationic protein, and the P-selectin. The evidence supporting the treatment options for recurrent chronic rhinosinusitis with nasal polypi indicates that the mainstay of the treatment should be intranasal steroids, complemented with short courses of steroids, occasional short courses of antibiotics, and always saline irrigation. Only steroids are given the grade A recommendation. Generally speaking, the control of chronic rhinosinusitis with nasal polypi would depend more on steroids than antibiotics, in contradistinction to chronic rhinosinusitis without nasal polypi. There is also good evidence to support aspirin desensitization in those patients who have aspirin sensitivity. And despite using these current standards, about 1/3 of the patients would still have their disease uncontrolled by the end of the treatment courses. How effective are intranasal steroids in the management of nasal polypi? There is a large body of evidence supporting the effectiveness of intranasal steroids over placebo in the control of patients' symptoms, including nasal obstruction, nasal discharge, loss of sense of smell, and even to some extent reduction of the polyp size as well. There is low incidence of adverse events with the intranasal steroids, particularly nasal irritation and epistaxis. And the different formulas for the intranasal steroids don't differ much in their effectiveness, but they differ in their absorption systemically. The second generation compounds have a bioavailability less than 1%, and this makes it a safer drug for long-term use and use without any treatment breaks. Does it matter which method is used for the delivery of an equivalent dose of intranasal steroids? Yes, it appears that for those patients who have moderate or severe symptoms with nasal polyps, the use of nasal drops rather than nasal sprays would be more effective. Perhaps the use of drops would allow the solution to trickle across the nasal polyps easier. And in patients who have open sinus cavities after previous endoscopic sinus surgery, the use of an equivalent dosage of intranasal steroids diluted in high volume of saline, like 240 milliliter for nasal irrigation rather than sprays or drops, is also more effective in reducing the symptoms and preventing recurrence of the nasal polypi. And these are the supporting evidence for the effectiveness of the intranasal steroids in the management of chronic rhinosinusitis, either without nasal polypi or with nasal polypi. Starting with this meta-analysis study, which compared the effectiveness of the intranasal steroids in controlling the patient's symptoms. The outcome measure here was the symptom scores in two groups of patients. The first group was about 600 patients in several studies. The steroids group had a better result than the placebo group, and in the other subgroup with nasal polypi, the effect size is even more, showing clearly that the intranasal steroids were much more effective in controlling the patient's symptoms than a placebo. And in this meta-analysis study, comparing the results of intranasal steroids versus placebo and the proportion of responders to nasal polyp score, it compared the placebo group with collectively 400 something patients against patients who had the intranasal steroids, again 450, and the effect size is clearly in favor of the patients who have intranasal steroids, and that was the trend with all the studies included in this meta-analysis. Further evidence from another meta-analysis study, including 7 different randomized controlled trials on several hundreds of patients, divided into 2 groups. The study compares the effectiveness of intranasal steroids versus a placebo in patients who had previous endoscopic sinus surgery with presumably open sinus cavities, and those who had not had any previous surgery before. And it's clear that intranasal steroids have more effectiveness than placebo in both groups, with the effectiveness of intranasal steroids in the group who had previous nasal surgery with open sinus cavity a much higher effect size. In summary, there is high quality evidence that long-term use of intranasal steroids in patients who have chronic rhinosinusitis with nasal polypi is effective and safe. There is also high quality evidence that the use of the intranasal steroids have good impact on the patient's nasal symptoms and to a lesser degree on the patient's quality of life. The impact of the nasal steroids on patients who have chronic rhinosinusitis with nasal polyp is much higher than their impact on patients who have chronic rhinosinusitis without nasal polyp, almost a 3-fold increase in the effect size. There's also evidence that there isn't much difference between the different types of nasal steroids. but there is some difference between the delivery methods. Some delivery methods like high volume saline irrigation and nasal drops are better compared to the use of nasal sprays. There is also evidence that the use of nasal steroids in patients who have polyps would reduce to some extent the polyp size and also may help in preventing polyp recurrence after endoscopic sinus surgery. The intranasal steroids are well tolerated and there is very mild to moderate reports about side effects, including nasal irritation and epistaxis, and there is not much evidence that it actually increases the intraocular pressure or cause lens opacity and cataract. The effect of nasal steroids on improving the sense of smell in patients who have nasal polypi is poor compared to the effect of systemic steroids. Nasal steroid sprays don't reach the olfactory mucosa area in sufficient levels due to the intervening polyps and tissue edema. It is here that the use of nasal drops have more effect than the use of steroid nasal sprays, but the nasal steroid drops should not be used beyond 6 to 8 weeks. They can be used initially before shifting to nasal sprays after that. In patients with severe symptoms or in whom the nasal steroids alone has failed to achieve adequate control, it may be worth considering giving short courses of systemic corticosteroids, something like oral prednisolone at a dosage of half milligram per kilogram body weight with a maximum daily dosage of about 60 milligrams. A Cochrane review of 8 randomized controlled trials has shown that the effect of oral steroids compared to the effect of a placebo or no treatment showed significant improvement in polyp size, in nasal symptoms, and in the quality of life as well. The effect would last for up to 3 months, and it was given a grade A recommendation with a caution that the short courses should be once or twice only per year. Nasal irrigation with either isotonic saline or Ringer's lactate has shown efficacy in the management of chronic rhinosinusitis with and without nasal polypi. Some additions like xylitol, sodium hyaluronate, and xyloglucan had added benefit as well. Other additions like baby shampoo, honey, or dexpanthenol, as well as higher temperature or higher salt concentration does not confer any additional benefit to the standard nasal saline irrigation. Regular nasal saline irrigation improves the function of the nasal mucosa through several effects. It mechanically removes the dried mucus and crusts. It can also improve the mucus clearance, enhance the ciliary bead activity, and it disrupts the accumulation of things like antigens, biofilms, and inflammatory mediators, and also increases the hydration of the sol layer. Nasal saline irrigation can also transport things like nasal steroids medication into the sinuses. It's interesting to note the results of this randomized controlled trial, in which patients with chronic rhinosinusitis with and without nasal polypi were randomized into 2 groups. A group has received long-term antibiotics. This study, it was erythromycin for 12 weeks, plus the usual nasal saline irrigation and intranasal steroid. The other group had endoscopic sinus surgery, followed by short-term postoperative antibiotics, again erythromycin and nasal saline irrigation with dexarhino spray for 2 weeks, followed by intranasal corticosteroids. The results of the 2 groups after 3, 6, and 12 months showed no differences between the two groups, the surgical and the medical, with long-term antibiotics, and also there were no significant differences between the two subgroups, either chronic rhinosinusitis with or without nasal polypi. And then came the monoclonal antibodies. These monoclonal antibodies has been used earlier in the management of asthma. Its effect on the control of chronic rhinosinusitis with polyps was investigated by several randomized controlled trials. These monoclonal antibodies are supposed to directly target the inflammatory pathway responsible for the development of the polyps. Things like omalizumab, which is an anti-IgE, mepolizumab, which is an anti-interleukin 5, and Dupilumab, which is an anti-interleukin 4 and 13. These randomized controlled trials showed significant reduction both in the symptoms of the patient and in the polyp size. Clinically significant reduction in the polyp size was noted in 60% of the patients who were on polizumab and 70% of the patients who have Dupilumab. It has a medium effect size on the management of the patient's symptoms. The main drawback of these monoclonal antibodies are the high cost, the risk of anaphylaxis, and the frequent subcutaneous injections. Dupilumab has gained the FDA approval for the treatment of nasal polyposis. It effectively and directly blocks the type 2 inflammatory signaling. This is the inflammatory pathway responsible for the production of nasal polyps in Caucasians and in the Western population. It achieves this by blocking the interleukin 4 and interleukin 13. This leads to a significant reduction in the nasal polyp score and a reduction of a polyp size in 70% of the patients compared to 20% for the placebo group, and also a reduction in the patient symptoms score. The current evidence suggests that Dupilumab has the most robust evidence for use in the cases of chronic rhinosinusitis with nasal polypi in Caucasians and the Western population. Several other biologics had gained the FDA approval. Omalizumab has gained the FDA approval for the use with chronic rhinosinusitis with nasal polypi. It blocks the IgE inflammatory response. It has some side effects like sinusitis, headaches, and pharyngitis, and reaction at the injection site. Mepolizumab is an interleukin 5 and has only gained the FDA approval for the management of eosinophilic asthma. Dupilumab has gained the approval for the treatment of chronic rhinosinusitis with nasal polypi plus atopic dermatitis. The main side effects are nasopharyngitis, headaches, and again a reaction at the site of the injection. And this meta-analysis of two randomized controlled trials has provided the evidence that Dupilumab, the anti-interleukin 4, is effective in the management of nasal polyps. In both groups, the Dupilumab and the placebo group, there was continuous use of topical nasal steroids, but in the Dupilumab group, the number of patients who avoided nasal surgery for recurrent polypi was significantly higher than the number of patients in the placebo group. The effect size is obviously significant. Aspirin sensitivity should be suspected in patients who have severe polyp disease, especially those who have recurrent polyps or intrinsic asthma. The surgery is usually less successful in aspirin sensitivity, with relapse occurring quite early. The diagnosis would be established with a clear history of 2 or more induced reactions after aspirin or other non-steroidal anti-inflammatory medications, or by a positive aspirin challenge. The sensitivity to aspirin is associated with severe rhinosinusitis, asthma, increased intensity of eosinophilic inflammatory response, and of cytokines, particularly interleukin-5. The rationale for aspirin desensitization came from the observation that after an aspirin challenge, the patient would have a refractory period of 2 or 3 days, during which further doses of aspirin may not lead to any deterioration in their condition. It was found that regular administration of aspirin would be associated with a decrease in the patient's symptoms for both upper and lower respiratory tract inflammatory response. The protocol most widely used for aspirin desensitization is the Scripps Clinic oral aspirin desensitization, in which the dosage of the daily aspirin is increased gradually up to 625 milligrams twice daily. This may cause some GIT disturbance. There is some evidence that lower doses of aspirin at 100 milligrams daily dose can also be effective in the desensitization. And this meta-analysis of 2 randomized controlled trials provided the evidence that aspirin desensitization is actually effective in reducing the patient's nasal symptoms and improving the quality of life in patients who have a chronic rhinosinusitis with nasal polypi. Another cause for recurrent and refractory nasal polypi is the allergic fungal rhinosinusitis. This is a subset of the chronic rhinosinusitis with nasal polypi characterized by eosinophilic mucin and non-invasive fungal hyphae, and the patient has a type 1 hypersensitivity to the fungi. Unfortunately, randomized controlled trials have showed no benefits of antifungal therapy either locally or topically in the patients with chronic rhinosinusitis with nasal polypi. And this is the meta-analysis study of 3 randomized controlled trials that showed that oral antifungals have no effect in the prevention of recurrence in allergic fungal rhinosinusitis. No effect. Another meta-analysis study of 3 randomized controlled trials, this time investigating the effect of local antifungal treatment versus a placebo on nasal polypi. The results did not show any positive effect on the quality of life, the symptoms, or the signs of the disease of the allergic fungal rhinosinusitis disease. In fact, the placebo group has a better response than the local antifungal group. By this, we come to the end of this presentation on the non-surgical management of nasal polypi. Assalamu alaikum.